Okay, so my presentation is on glenohumeral dislocations and subluxations. First up, we'll talk about the anatomy of the shoulder and shoulder girdle. The bones of this joint are the bones involved in this articulation are the scapula, humerus, and clavicle. The bony landmarks on each bone are the glenoid fossa, the coracoid process, the acromion process, supraglenoid tubercle, infraglenoid tubercle, which are all on the scapula, and then the head of the humerus and the greater and lesser tubercles or tuberostomies. Next, we have the ligaments, and the ligaments involved are the superior glenohumeral ligament, the middle glenohumeral ligament, the inferior glenohumeral ligament, the glenohumeral joint capsule, and the coracohumeral ligament. The bursas within the articulation are the subacromial, the subdeltoid, the subscapular, and the subcoracoid bursa. Next up, we have the muscles. There's the supraspinatus, infraspinatus, subscapularis, teres major and minor, deltoid, latissimus dorsi, and pectoralis major. There's a bunch of other little muscles that are part of the shoulder and shoulder girdle, but these are the primary movers of the shoulder. Next, we have the pathology for dislocation. So an anterior dislocation happens when the humeral head is forced anteriorly out of the articular capsule and past the glenoid labrum, and then the humeral head then falls downward to rest under the coracoid process. There's a lot of complications that come along with anterior dislocation, such as torn capsular and ligamentous tissue, the possibility of tendinous avulsion of the rotator cuff muscles or the long head of the biceps, possible injury to the brachial plexus, profuse hemorrhaging, and possible glenoid labrum pathology, which promotes joint instability. And then the pathology for posterior dislocations, the humeral head is forced posteriorly out of the articular capsule. This type of dislocation is extremely rare. It only occurs in about 1 to 4.1% of all shoulder dislocations. Similar to anterior dislocations, there are also complications that come with a posterior dislocation, such as similar soft tissue damage and avulsion fractures of the left tuberosity caused by the subscapular tendon. Next, we have the subluxation pathology. Subluxations are caused by excessive translation of the humeral head without complete separation of the joint surfaces. As we all know, a subluxation is when it's kind of like a dislocation, except it goes back instead of staying out of place. There are brief occurrences, and the humeral head quickly returns back to the glenoid fossa, and this can occur posteriorly, anteriorly, or inferiorly. Next, we have the mechanism of injury. For an anterior dislocation, the mechanism is a forced abduction, external rotation, and extension. You see this in tackles with football, rugby, or abnormal force in a throw. The picture here is of the javelin thrower in the Olympics who dislocated her shoulder during a throw. For posterior dislocation, the mechanism is forced adduction and internal rotation, so pretty much the opposite of an anterior dislocation. And this can be caused by falling on an extended arm or falling on an extended and internally rotated arm. The mechanism for subluxation is repetitive arm movement with an outstretched arm, such as throwing punches and boxing. The signs and symptoms for an anterior dislocation are a flattened deltoid contour, palpation reveals prominence of the humeral head, the patient carries the affected arm in slight abduction and external rotation because that's the most comfortable position for the dislocated shoulder to be held in. Patients are unable to touch the opposite shoulder, and they have moderate pain and disability. The signs and symptoms for posterior dislocation are severe pain and disability. The arm is held in adduction and internal rotation. The anterior deltoid is flattened. The acromion and coracoid processes are prominent, and the humeral head may be seen posteriorly. The signs and symptoms for subluxation are just pain and irritation around the joint area. I have that here. Subluxation signs and symptoms are stiffness, mild pain, and joint instability. There aren't any special tests for dislocation and subluxation. Dislocations and subluxations are typically diagnose through observation because there are very obvious visual deformities for dislocation. Most of the special tests for the shoulder are for glenohumeral instability. Predisposing factors for subluxations and dislocations are throwing sports, contact collision sports, sports with a forceful extension of the arm, so seen in boxing, tennis, and track and field throwing like javelin or shot put. And then congenital atraumatic instability, which we'll talk about later when we go over glenohumeral joint instability. Next, we have recognition. Like I said earlier, especially dislocations are mostly diagnosed through the observation part of our evaluation. For an anterior dislocation, the patient carries their affected arm in slight abduction and external rotation. And for a posterior dislocation, the arm is called an adduction and internal rotation, like I previously stated. You can also use x-rays for your recognition of dislocations. There's a sign on an x-ray called the light bulb sign, and it shows internal rotation of the humeral head on the x-ray. And then the top picture on this slide is of a posterior dislocation, and then the bottom picture is of an anterior dislocation. Some differential diagnoses of dislocations are bony anatomy fractures, such as clavicular fractures, vertebrosity fractures, and fractures of the humeral head. Other differential diagnoses include rheumatoid arthritis, rotator cuff injuries, acromioclavicular joint dislocation, glenoid labrum tear, shoulder subluxation, and axillary or suprascapular nerve palsies. Some differential diagnoses for subluxations are glenoid labrum tears, acromioclavicular joint injury, clavicle fractures, shoulder dislocation, swimmer's shoulder, bicipital tendonitis, and rotator cuff injuries. The initial management and treatment for dislocation is immediate immobilization in a comfortable position. On field, a lot of times you will see them use like a shirt or a sling with a small folded towel or a small pillow placed underneath the arm. So, and then following the immobilization in a comfortable position, there needs to be immediate reduction by a physician. Physicians typically reduce an anterior dislocation on the field using the Milch technique, which utilizes elevation and external derotation of the arm placed in minimal traction. And for posterior dislocations, the patient may have to be under anesthesia for the reduction to be performed. And after the reduction, you need to control the hemorrhaging with cold packs and ice packs. Post-reduction management, muscle reconditioning should be initiated as soon as possible, and the immobilization should continue for 3 weeks after the reduction. An anterior dislocation, the arm is immobilized in a position of adduction and internal rotation. And with a posterior dislocation, the arm is immobilized in a position of external rotation and slight abduction. While immobilized, the patient should perform isometric exercises to strengthen the internal external rotator muscles. The strength program should progress from isometrics to resistance band exercises, and then to dumbbells, and then to other resistance devices as soon as pain allows it. And then a major criterion for return to play with shoulder dislocations is internal and external rotation strength that equals 20% of the patient's body weight. Referral and immobilization, an athlete or patient with dislocation should be referred to a physician for immediate reduction. The arm should be mobilized in a comfortable position prior to reduction, and then the immobilization should continue post-reduction for 3 weeks. So the picture on the right is like a shoulder brace that holds it out to the side, and then on the left is the normal sling that we all think about when we think of the shoulder sling. Next, we have the prevention. Since dislocations are typically traumatic in nature, they're difficult to prevent, but strengthening of the surrounding muscle groups could help with the speed of recovery, as well as preventing glenohumeral instability that usually follows or leads to dislocation. And the same thing with subluxations. The subluxations could be prevented a little bit through strengthening the surrounding muscle groups. There is no mulligan technique for a dislocation because they require immediate reduction, so mulligan technique's not really going to do anything. Next references, 2 slides reference. Like I said, 2 slides references, and then here's my PICOT analysis slide. A condition that goes hand in hand with glenohumeral dislocations and subluxations is glenohumeral joint instability. This is classified as the inability to maintain the humeral head in the glenoid fossa. The integrity of the glenohumeral ligaments and the glenohumeral is disrupted, causing instability. This instability can be either atraumatic or traumatic. The traumatic cases of instability are usually caused by dislocations, and the instability can be anterior, posterior, inferior, or multidirectional. So the atraumatic instabilities can be broken down into 2 groups. The first being congenital, which is laxity of structures in the shoulder, which may be present at birth, and then chronic recurrent, which is typically seen after surgery for dislocation, or microtrauma that can lead to the instability. Then traumatic instability is caused by dislocations, and anterior dislocation due to trauma is the most common type of instability. Anterior joint instability accounts for 90% of all recurrent instability, usually results after an acute anterior dislocation, and it can also make anterior dislocations more likely to occur. Posterior instability typically occurs after subluxation rather than dislocation. And then multidirectional instability means that the instability is in more than one plane of motion, usually a combination of anterior inferior and posterior inferior laxity. And then the last type of instability is inferior instability, which is typically found in conjunction with anterior posterior instabilities. Like I said before, most of the special tests in this presentation are for glenohumeral instability, and they are as follows. So the first one is anterior apprehension. The patient's involved shoulders at 90 degrees of shoulder abduction and 90 degrees of elbow flexion. The clinician slowly externally rotates the shoulder, and then a positive finding in the test would be if the patient looks apprehensive or expresses feelings of apprehension of further movement, and it is indicative of an anterior instability. Next, we have the posterior apprehension test. The clinician places the patient's shoulder 90 degrees of flexion in an internal rotation, and then the clinician applies a posterior force through the long axis of the humerus. A positive test for posterior apprehension is if the patient looks apprehensive or expresses feelings of apprehension of further movement, like with the anterior apprehension test, and this is indicative of posterior instability. The sulcus test sign can be seen when the patient is sitting with their forearms and hands resting in their lap. The clinician stands with the proximal hand grasping the patient's scapula and the distal hand grasping the subject's elbow. The clinician stabilizes the scapula and then applies an inferior force with the distal hand, or also known as distraction. And in excessive inferior humeral head translation with a visible or palpable step-off or sulcus deformity, you can see the step-off or sulcus deformity in the top rightmost picture. And this test is indicative of inferior multidirectional instability. The next test kind of has a lengthy explanation, and the picture's not so great, so I apologize for that. The anterior drawer test is performed with the patient lying supine with the glenohumeral joint near the end of the table. The clinician stands next to the involved shoulder, placing one hand around the humerus below the surgical neck and stabilizing the scapula by placing the fingers behind the spine of the scapula and the thumb over the corporate process with the other hand. The patient remains relaxed while the clinician passively abducts the glenohumeral joint 70 to 80 degrees, forward flexes 0 to 10 degrees, and externally rotates 0 to 10 degrees. While stabilizing the scapula, the clinician firmly glides the head of the humerus anteriorly and applies a slight distraction to the glenohumeral joint. A positive test has shown increased anterior translation of the humeral head relative to the scapular and glenoid fossa, and this is indicative of anterior instability. Posterior drawer. is performed with the patient lying supine again with their shoulder passively abducted 30 to 70 degrees and horizontally flexed 20 to 30 degrees. The elbow is flexed but relaxed. The clinician holds the patient's arm at the elbow and stabilizes the scapula by placing the other hand posterior to the shoulder joint capsule with the thumb over the foregut process. With the scapula stabilized, the clinician applies downward pressure, pushing the humeral head posteriorly. Positive tests show increased posterior instability with the humeral head, and this is indicative of posterior instability. The relocation test is performed with the patient lying supine with the shoulder in 90 degrees of abduction and full external rotation. The clinician stands with the distal hand grasping the patient's wrist and hand, and the proximal hand is placed over the patient's humeral head anteriorly. The clinician then applies a posterior force to the humeral head while externally rotating the patient's humerus. Positive test shows a reduction of pain and apprehension and commonly an increase in shoulder external rotation. This test is indicative of anterior instability. And then the last test is the Inferior Drawer or Feagin's test. The patient is standing with the involved arm abducted to 70 to 90 degrees and the elbow extended, and their arm is resting on the clinician's shoulder, as you can see in the pretty archaic photo to the right. The clinician then stands to the side of the patient and clasps his or her hands together around the upper middle thirds of the humerus. The clinician attempts to glide the humerus in an anterior and inferior direction. Positive tests would show excessive gliding of the humerus, and this test is indicative of anterior and inferior glenohumeral instability. And that is all for my presentation about glenohumeral dislocation, subluxation, and glenohumeral joint instability.